This is my journal club on the effects of pre-oxygenation endpoints on safe apnea time using high flow nasal oxygen for women in labour, a modelling investigation. So a couple of reasons why I chose this. Firstly, because I do a lot of obstetrics, so I thought it'd be useful to look at something to obstetrics. And secondly, I don't really know much about modelling or computer modelling for investigation, so I thought it might be interesting to have a little chat about that. So as a background, as we all know, achieving safe apnea time via adequate pre-oxygenation is the key component to giving general anaesthetics. And the Obstetric Association of Anaesthetics and Difficult Airway Society recommend you should have an end time of oxygenation of at least 90% before proceeding to intubation. That's using a tight face mask technique. So in obstetrics, it's well recognised that several factors that make this difficult to achieve. And for those of you that have done exams, I'm sure you'll well know these, but those are, human factors in terms of urgent surgery, that often the patient, the idea is that they want to be done using a regional anaesthetic so they can meet their baby. So a general anaesthetic is typically not on plan A, and the patient may be agitated, and so it may be difficult to actually oxygenate them, and the positioning might not be quite as good. And even with optimal pre-oxygenation, the physiological change of pregnancy results in more rapid desaturating, shorter apnea time. So it's well described that pregnant ladies have got a reduced functional residual capacity, that they have increased oxygen utilisation, that they've got increased minute ventilation, and they've got increased closing capacity. So they desaturate much faster, and so they also have a higher risk of having a difficult airway and running into difficulty, as well described in NAP 4, I think. So high flow nasal oxygenation is increasing and becoming more widespread in anaesthesia, particularly things like ENT. But there's a lack of evidence for its efficacy in obstetrics. So that's the idea behind this study. So before this study, there have been 3 studies that have demonstrated that pre-oxygenation with high flow nasal oxygen versus tight-fitting face mask is inferior. So that's using healthy pregnant volunteers and looking to see whether having a mouth open or mouth closed makes a difference. So having your mouth closed means that you're more likely to have a higher attained fraction of expired oxygenation for pre-oxygenation. And interestingly, even if you extended the time you're pre-oxygenated for, so up to 8 minutes or so, you didn't improve your proportion of volunteers achieving that gold standard of a fraction of 90% oxygenation. So it does make sense if you think about it, but it was quite interesting to find out that actually you're not able to obtain the same oxygenation that you would do with a tight-fitting oxygen mask. So the methodology for this paper, due to ethical and practical difficulties, as we've kind of described, they used a very high fidelity model of respiratory and cardiovascular systems, which by the Nottingham Physiology Simulator, and this is validated for investigation in pre-oxygenation in healthy adults. And there's been quite a lot of publications associated with it, just having a little look for myself. They used the maximum rate of oxygen that they could, so 70 litres per minute for the high flow nasal oxygen. And they created or modelled 10 virtual subjects of 5 varying BMI levels, and then whether they're in labour or not. So if we look at the baseline physiology value, so this is quite a busy slide, but I think it actually just proves how complex and how clever their system is. So first of all, obviously you've got the weights of the different patients, but as a result of their weight, their tidal volumes also change. And we know that the tidal volume increases when you're pregnant. So they've done that to mirror for the subjects, as well as your minute ventilation. So your respiratory rate also increases when you're pregnant. So that's also modelled in. They've left the functional residual capacity being the same, as well as the dead space ventilation. And they've even altered the shunt fraction that you'd expect, and mirroring your increase in cardiac output that would happen in pregnancy, as well as your increase in heart rate and the increase in blood volume that you expect. So it's been really quite complex. You could argue that maybe one of the limitations is they haven't adjusted the hemoglobin concentration. We do know that actually in pregnancy you have a sort of physiological anemia, but an increase in your total plasma volume, don't you? So you could say that's perhaps a limitation, but I think that's maybe being a bit picky. And as well as they've increased your oxygen consumption in keeping with being pregnant, but also increasing when you've got BMI, which we know that happens as well. And the respiratory quotient is the same for all of them. So in terms of results, I'll show you the tables in a minute, but use of high flow significantly delays desaturation in all subjects in comparison with standard face mask technique. And it took about 12.5 minutes for your SATs to fall from 90% to 40% in the highest BMI model in labour. So for those, they've accepted that you're not really able to get to a fractional expired oxygenation of 90%. So that's for someone who gets to about 60%, and it still takes 12.5 minutes for them to get from 90 to 40. Whereas 3.7 minutes in the lowest BMI just using the face mask, so no high flow oxygen. Presence of labour, high BMI, particularly 45 and 50, significantly shortened the safe apnea time. So this is a bit of a worry, really, because these are patients that you think you'd get the most benefit from, but they're the ones that are actually getting the least marked increase in the safe apnea time. So this table is for the subjects not in labour. So interestingly, I think from this is you can see that if you've got a low BMI, you can almost go on forever with your high flow nasal oxygen. So even after 120 minutes, they don't get to SATs below to 40%. So it's 120 minutes, they got to SATs of 84%, and that's been completely apneic. Wow. For someone with a normal BMI with a closed glottis using their model. But as you go towards the right-hand side, but even this is not in labour, you will see that the BMI 50, you are still seeing an increase, but it's much less marked versus those with the low BMI, and that having a closed glottis increases the time period that you'll be able to achieve. So in labour, it's even more marked. So if you're in, which makes sense. So if you're BMI 50 and in labour, then you get the least response to it. And then it just gives you the different time periods it takes to go from. So on the left-hand side, where you can see 60, 70, 80, 90, that's the fraction expired at the start of their study. So we've already accepted that it's actually quite rare to be able to get to 90%. So you're probably, if you're using high flow, you might only get to 70% in 3 minutes or so.
So does it give a time if you haven't been able to use high flow, or not really do a very good job of pre-oxygenation at all?
No, so that's part of the limitations of it. Is it's assuming that if you're using the face mask, then it's assuming you've done like 3 minutes of pre-oxygenating, and you've got a fraction expired of 90%. And then that's also the same for these, and that's what they're assuming your end tidal oxygenation is. So one of the things they say is that if you're planning to use high flow nasal oxygen in the pregnant patients, is that they should be applied as soon as possible. To allow time for them to start being optimized. I guess the benefits of doing that are that it's not obstructing the airway, so it's probably really better tolerated. I mean, we'll come on to talking a bit more about the limitations, but they're using your maximum flow rate, so there's a variation in terms of what they can do. Most of the high flows that I've come across, they max out at 70 litres per minute, but you often not tolerate going straight up to the max. So you'd often have to start off lower and ramp up. So that's one of the limitations, I think, of the studies, that they haven't done a ramp, and they haven't given you other flow rates for those patients. But the model is sophisticated enough that it is assuming that you're in like left lateral position, but it doesn't mention anything about other changes of position. So if you are high BMI, then you might consider putting them in the Oxford pillow or in a more ramped position, but it doesn't sort of mention those. So high flow nasal oxygen provided superior safe apneic times in all models compared with face mask oxygenation with the same starting fractional expired oxygen. When you managed to get to the 80 or 90%, then there was a significant increase in safe apnea time, which reinforces applying it promptly and using it at the maximum tolerated flow rate are going to be advantageous. So what are the strengths of this study? I think that the utilisation of using a computer modelling allows us to look at an issue that would be otherwise extremely challenging, I would argue impossible to do clinically. You're not going to get ethical approval to suddenly start doing GAs on mothers. The range of BMIs chosen are in keeping with them seen in our population. I would agree with that, and it gives you a range from 24 to 50. It's very rare you're going to have a BMI more than 50, I think. And then I do. And I think the models seem remarkably robust in terms of respiratory and cardiovascular dynamics, and there seems to be a lot of thought that's gone into them. I did look at the paper where they first published using it, and they've adapted it as they've gone through, and it seems to be remarkably accurate. In terms of the limitations, I've kind of mentioned many of these already. So the maximum flow rate used, so my concern is patient tolerance, and perhaps using other flow rates or ramp increasing may be more useful. The validity of the model, I can't say I completely understand how they've actually managed to do all the modelling. I probably wouldn't even if I got shown it. It does say that it uses left lateral, but fails to mention ramping or changing positioning. And they've used rocuronium for an RSI. I think that's to avoid the problems of modelling with sucks when you're suddenly going to increase your muscle usage. I guess that's an interesting point that we can kind of talk about, in that those of us that have done a GA section recently, did you use sucks as your muscle relaxant? Because that's what I've been taught to use. And I still think I probably would use sucks. But I guess if you had a really high BMI patient, you potentially might be better off using rock. And I also think it's important to remember again that in pregnancy you need to give a higher dose of sucks. So my gut instinct is I always give 2 full syringes of sucks pretty much if I'm doing an RSI in obstetrics. And I seem to be an outlier in the fact that I draw it up in a bigger syringe rather than just the normal 2 ml syringe, if I just to reinforce it for me that I know that I'm going to give a bigger dose. But I don't know. You can take it without pinch salt if you want. And then I guess this is the key limitation: the practicalities of using high flow nasal oxygen in the delivery suite, especially for emergency cases. So, firstly, organisational. Getting the patient, because most of the patients who are going to be needing a GA, or you might be thinking about doing a GA, are going to be emergencies. In fact, I'd say virtually all. So the challenges of already having to apply monitoring, etc., getting things ready, your ODP, you're busy, but applying that high flow nasal oxygen, but you could do it. It'd be particularly useful for those really high risk patients that you're worried about doing GA on anyway. Then there's the cost implications. So the cost implications of actually having the equipment, the training, and then if you want to get the maximum benefit, you're going to be using it in emergency scenarios, there's probably been quite a few people you're going to be applying for that you're never going to end up doing a GA for.
And what's the teaching, because you've done your obstetrics with consultants fairly recently, what's their sort of teaching for the GA section? Like what do they tend to tell you to do?
So the consultants that I've only done a handful of GA sections.
I mean, I've done 2 ever. So.
I did one a couple of weeks ago overnight, and that was with Radka, who was comfortable using firearms. And the other GA section that I've been involved in was with Ed View, and I took over from him in the morning, and he used firearms.
Okay.
But if it was me by myself, I've seen Thaya used a couple of times, but actually using it myself and I haven't. I know the doses and all that kind of stuff, but
what dose do they use? Like 15 mils.
So you end up.
So they give the full 20. So whatever, 500 milligrams.
My case has been looking at my obstetric cases. I've done virtually all my GAs at the start of my career, which is when everyone used Thaya, and I just used the 20 mils. There's never a time when I've used less. But
it gives a very clear endpoint, so it should be fine to but
And no opioid unless they're pre-eclamptic.
No opioid unless pre-eclamptic, and then maybe use a bit of alpha, and then as soon as baby's in, get some.
Yeah.
And do they tell you to put the nitrous on?
Radka did.
Yeah.
Ed did, yeah.
I don't know if I did a GA section at the time. Did you? I don't think I did.
No.
I did lots of.
Actually, I think I did one elective, but.
One elective.
Yeah.
It's also flow practicalities, high flow. whether the delivery suite will have the ability to pump that much.
Yeah, so whether you've got enough flow, but also the other thing about high flow is in the COVID times, like, you know, aerosol generalization is another thing you have to consider. And then in terms of, so I think any uptake of things like high flow have probably been pushed back because of it. So what are my takeaway points? My takeaway points are that high flow nasal oxygen provides superior safe apnea times in pregnant women, despite generating a lower end-tidal oxygenation after pre-oxygenation versus a tight mask. I did know this, but I'd kind of forgotten. Because women have got an increase, pregnant women have got increased minute ventilation, they actually are able to achieve that end-tidal oxygenation faster than a normal patient would do. So that is one of the few reassuring things, that if you actually need to a GA section, they're able to achieve that, they're to get to that safe period a bit faster.
Yeah.
This improvement is only modest in high BMI patients who are in labour, but given that these cohort are most at risk for airway obstruction and difficult airway, I would still argue that this could be potentially life-saving. So whilst you might only be increasing it by 2 minutes, 3 minutes, that could be a big difference between their SATs getting to 92%, getting to 60%. There are likely still significant organisational, cultural, financial challenges before high flow nasal oxygen becomes established on delivery suite.
Is there a high flow?
I don't think so.
I don't think so. I think you'd have to.
Because I think I
request
used to
it.
struggle to get one down in the emergency theatre for takes.
Oh, yeah.
Oh, sorry, I didn't teach you.
That's right.
You guys are right back.
Yeah, sure. So what do people think about the paper? Anyone have any views? If there was the option of using high flow nasal oxygen in obstetrics, do you think you'd use it?
Yeah, definitely. I think in a patient who's got a high BMI, that you're worried that there might be a difficult intubation, I think it would be very, very reassuring to have it. And it's good. It's kind of obstetric. You know, it's a paper that sort of reiterates what you suspected was the case anyway, isn't it? It's just intuitively you'd think that high flow would be better at maintaining that.
Am I right in saying that the high flow apparatus itself takes time to warm up?
Yeah.
All that kind of stuff. So I think in principle it's a great idea.
Yeah.
I think practicalities and logistics mean that it will be difficult to use unless you have a high flow on standby permanently.
Should they do it at night?
Do they?
Yeah. I think that it's made me think that if we'd had one that and there wasn't other stuff going on, then it is something that perhaps I would, like say for example, you had someone who's high BMI, or you're worried about having a big bleed or something like that.
Yeah.
Like I think actually it might be useful in those patients that have bled and then come to theatre and you're worried that you might have to do a GA section or a GA that they've already delivered. It might be useful for those. But I think I don't think you're ever going to be able to take the ones that have suddenly come in and suddenly got to do a Cat 1 section, but it might be useful for those that you're worried about and that you can kind of make a plan, and it will improve when you've got a third on, because you'll go around with the obstetricians hopefully, and then if you're on just in charge of the delivery suite, and then you can kind of say, well, if this person comes, then I think we should use, high flow. And then, if they're starting to get worried about it, then I think I would accept the cost of trying to get stuff ready, or at least having it, next to the next thing. And then you could almost assign roles. So, the ODP is just going to do this, so I need someone else to put the monitoring on, or
for a GA section, you would normally have two. If the third one would come, you have, and so then maybe you'd have a second pair. The ODP could hopefully help out with the high flow, but we don't have a high flow. So
no, I mean you could still have high flow. I think you could use high flow when you're having a go at doing a spinal. So if it was like a cat 1,
yeah.
So where
a cat 1, you're already beginning to do it. It's off.
Is it worth putting nasal spec when you're pre-oxygenated as well? Because
I mean, I guess that's a low cost thing that you could start to do.
Yeah.
Is that you could say, if you're worried that it might go that way, or you are having a true one shot of doing a spinal,
Yeah.
you could just get them to stick a nasal specs. I mean, to be honest, you're not going to get that much flow in there, but you might be denitrogenating them a little bit.
But then have you used the nasal specs for high flow?
I have before.
Yeah. So you put on 2 litres while they're awake, and then the moment they're asleep, you ramp it up to 15 through the nasal specs, and that effectively it does work really well. So I just thought that would be quite a good idea, isn't it? If you're doing a spinal, like you say, because you've asked someone to pre-oxygenate when they're doing spinal anyway, so you could get them to put nasal specs on underneath.
You would lose your seal a bit, but I mean.
But I think it'd be worth it because you can never get an effective pre-oxygenation when you're doing spinal, and then because inevitably they'll lose the feel when you reposition to the GA. So I think it's just. I think that's probably what I would think about.
Cool.
Sounds like an interesting model.
Yeah.
Yeah.
It's really good, yeah. They've done it for like other things. I've never really heard of using simulated models, but yeah, and there's a couple of the papers they've done them pretty interesting, and like I struggle to punch holes in them, so.
I wouldn't know where to start in order to kind of find criticism.
No, I think you have to have quite a lot of healthy volunteers and have quite a lot of data, and have a big data pool, and then you're able to create it from.
So then you just type in whatever scenarios you want, or program it to run certain things.
Yeah.
You can see how it could be done.
I'm gonna stop on that one.
Yeah. Cool. Thanks, Jamie.
No worries.